Good evening, everyone. My, oh goodness, this is a full house. Those of you who are coming in the door, just settle down. You're young enough to feel comfortable on the floor. I'm going to be very brief because you came to hear Dr. Berkowitz, not to hear me. But I am delighted that we have so many, not only our students here, but so many alumni, some of whom I have not seen in quite a while, a large turnout of faculty. And that tells me two things. You want to hear Bobby Berkowitz, but you really want to hear what she has to say because it is such a timely topic. I just want to tell you a little bit about the history of this lecture. We have many lectures in the College of Nursing and visitors, but this particular one was established 33 years ago, and it was on the occasion of the 25th anniversary of the College of Nursing. And at that time, we only had one program here. It was the baccalaureate program. And it was decided that we needed to do something special to mark that 25th anniversary. And it was to establish this lecture to bring in distinguished nurse leaders and some others that would really give our students an opportunity to hear them, to meet them, and to take away from this lecture some important information that they would use in their careers. And so that is the history that we have continued year after year after year. Our first lecturer is someone that Dr. Berkowitz and I know well, Margaret McClure, and many people in between. There were national and international leaders in our field. I am particularly grateful to the committee that was good enough to establish and to prepare the program for tonight, and also want to mention our Sigma Theta chapter, Alpha Nu, that's a co-sponsor, and our own Center for Global and Public Health. Dr. Berkowitz, Bobby, is most welcome here. I know what it was like for me a long time ago to leave New York City and come out here to this strange land. Well, she now lives in New York City, but she came all the way to New York from the state of Washington. How many, are any of you here from the West Coast? Raise your hand. West Coast people. I know we have 10 freshmen that are here from California, and we've had a couple from Washington and from Oregon. But she is like a breath of fresh air that's come across the United States to the city of New York, and so she is now our neighbor, and as one of her colleagues, deans, Bobby, I welcome you most sincerely, not only to Villanova, but to the East Coast. And so I hope you will all enjoy and take away with you the wisdom that I'm sure she's going to provide this evening. And Dr. Desilets will be introducing her. Welcome.
Well, since 2010, Dr. Bobby Berkowitz has been the Dean and Mary Mundinger Professor of Nursing at Columbia University School of Nursing, which is in New York, and also Senior Vice President for the Columbia University Medical Center. Before she came to New York, she was the Alumni Endowed Professor of Nursing and Chair of the Department of Psychosocial and Community Health at the University of Washington School of Nursing. And she was also an adjunct professor in the School of Public Health and Community Medicine there. She has been a distinguished leader in nursing and in public health. She led the National Program Office of the Robert Wood Johnson Foundation's Turning Point Initiative as a director and principal investigator. That program, which is now closed, was started in 1997. Turning Point created a network of 23 state partners and 5 national excellence collaboratives to transform and strengthen the public health system in the United States. Many of its products are still available for use. Prior to coming to the University of Washington School of Nursing, Dr. Berkowitz held leadership positions in both state and local governments. She was a Deputy Secretary for the Washington State Board of Health and a Chief Nursing Officer for Seattle-King County Department of Public Health. Dr. Berkowitz received her PhD from Case Western Reserve University and her master's and bachelor's degrees both from University of Washington. She is a member of the prestigious Institute of Medicine and has been elected a Fellow in the American Academy of Nursing. Dr. Berkowitz serves on the board of several journals, including Public Health Nursing, and as Associate Editor of Nursing Outlook. And she is the author of books on public health nursing leadership, nursing management, communications among healthcare organizations. Her research focuses on health policy and public health systems, primarily at the state level, as well as systems levels to eliminate health disparities. Please join me in welcoming Dr. Bobby Berkowitz, who will speak to us tonight on public health nursing, aligning public health and primary care.
Thank you for that very nice welcome. It's wonderful to be here. It's a great honor to be invited for this lectureship. It's kind of, when you come to Pennsylvania from New York, you're actually coming to the West Coast. You know, New Yorkers think the West Coast starts at the Hudson River. And I live on the Hudson River, and I can look across, and I almost think I'm home again. I've been in New York for about a year. I have a million fabulous stories about my adopted city. A lot of very funny stories, a lot of great experiences. I could fill my hour just telling you stories about New York City. But you didn't invite me to do stand-up comedy. You invited me to talk about something much more serious, which is public health and our role in primary care and our role in chronic disease. So I want to spend a little bit of time telling you why I care so much about this topic. It has a lot to do with the kind of work that I've done in my career, a little bit about what you heard about in the introduction, but just to give you a little sense of why I think this is important. So let's start with a little bit of a background. So my experience, both as a practitioner in public health, as a public health nurse for many, many years, in rural parts of Washington State. And then my experience as a public health nursing leader, chief nurse, executive in a couple of different health departments. And then my policy experience as a deputy secretary for a state department of health, the Washington State Department of Health. And then finally as an academic researcher. My research ideas, my practice ideas all come from a pretty pragmatic approach, which is what the literature has told us and what research has told us, but a lot about what my experience has taught me. And four pretty key areas that have framed what I'm going to talk with you about tonight are these 4 areas. One is that I was involved during my time at the Washington State Department of Health in an initiative that stemmed from Washington's plan in 1990 to do health reform. So this was before the Clinton health reform plan. This was before that. And Washington State was interested in finding ways and mechanisms to not just assure access to care for the population in Washington State, but to assure a healthy population, which is quite different than any other health reform mechanisms that have come along, including the one we have today. So we really thought about how do we assure the population in Washington State is healthier. And because of that, our health reform plan had this piece called the Public Health Improvement Plan. And that was really designed to assure that public health collaborated with its partners in health and healthcare and community-based organizations who contributed to the public's health. So it was really a very, we considered it a pretty powerful initiative to raise the visibility and the importance of public health in the state of Washington. And I worked on that for, as both a citizen. I'd been appointed to a governor's commission on health reform, and then as a policy person in the State Department of Health. And after I'd been at the State Department of Health about 3 years, the Robert Wood Johnson Foundation, who many of you know fund a great deal of projects and research in health and healthcare. The most recent effort there has been the Future of Nursing Report, which is a wonderful roadmap for all of us. They came to me and said, we're thinking about doing the kind of thing you've done in Washington, but at a national level. And that was the beginning of the Turning Point Initiative. So that's how I went from the state to become an academic, rather reluctantly. I had not envisioned myself being in an academic environment. I really loved practice. I really liked policy work, but I wanted to do this national initiative, and in order to do that, I went on faculty in the School of Public Health at the University of Washington. So we did this activity for about 10 years. It was a very long-term initiative, very long-term in terms of grant funding. And it's probably one of the most personally satisfying pieces of work I've done in my career. The reason for that is that it got me out into our country. We worked in 23 states and hundreds of local communities, working with local coalitions and state coalitions and people interested in improving the health of their communities, improving the health of their states, and basically improving overall health in the U.S. And so I got to see places in this country that I never would have seen just on my own, from very, very rural communities in Oklahoma to New York City was one of our sites, and everything in between. And because of the work that we were doing in terms of bringing coalitions of people together who cared about how healthy we are as a society, and not just how healthy we are because we have an absence of disease, but how healthy we are because of improving social conditions in which people can be healthy, working on societal and social conditions within communities. I gained a kind of new sense of the power of communities to change the nature of their communities. It was a very empowering 10 years, and it re-energized my optimism about what people in communities can actually do. And I just have so many, and I won't go into that because that's not the purpose of my lecture tonight, but I have so many wonderful stories about people in local communities doing really amazing things with very little except for a real commitment to improving the lives of people who they consider neighbors. So it was a great experience, but as all great experiences do, especially when they're grant funded, they come to an end. A couple things that I learned about that experience. One is that one of the major issues we have in this country that, depending on what statistics you look at, is actually getting a little worse, and that's health inequity or health disparities, the differences in health status within communities and across communities. And so the next work I decided I wanted to do was to get more involved in the research component of health disparities, and applied for and received a National Institutes of Health Center grant looking at research in health disparities. And from there, I was interested in getting, when that grant was coming to an end, I was interested in doing more work in public health. And so the next grant I had, and finished it up just before I came to New York, was one called the Public Health Experience with Health Disparities. And this was prompted in part because of two reports. One was the Surgeon General's report. This came out in 2006. Some of you may have looked at it. It really urged a national research agenda around health disparities, but the idea was to focus the new knowledge that we were gaining from research in health disparity and new technology to communities and organizations, so to make sure that we transferred what we were learning about health disparities from research, transfer that to change in communities, which was very much the kind of work that I had been doing in Turning Point. So it really rang true for me. And the second report was the NIH's strategic plan for health disparities research. They also said we ought to be targeting systems, infrastructure, training, public information outreach. Again, people in communities and the structures that support them is where we ought to be investing our time and attention and research. And then, of course, the statistics, even with all the work that's been going on in terms of healthcare, research in healthcare, the statistics show the continuation of a disparity gap and a lack of clarity about how to set priorities for improving health with populations. So all of this has led me to a real interest in terms of a focus of my own research over time. And that has been a couple of things. One is an interest in what are programs and structures within communities that are effective in eliminating health disparities and improving health equity in local public health. So what are those structures, systems that give us a better chance for health equity and eliminating health disparities? The other is to really thinking about the evidence base that's used in local public health to develop programs related to health equity and health disparities. So having practiced in local and state public health for many, many years, and then having done research in those same areas for a number of years, I still had questions and concerns about the evidence base that is used when developing new programs for health disparities. Are any of you here tonight from a local public health department or state health department? No, nobody, okay. Well, you know that, or you are probably learning, I know many of your students, that along with evidence and data, many decisions are made, especially at community level, through a political process. And those who work in local health departments and state health departments are very much the result of a lot of the programming is through political process. And sometimes that process has data attached to it. Sometimes it has evidence attached to it, but very often the purpose is very different. So policymakers may have a very great interest in doing something particular in a community, and the underlying ideas about the programs may or may not be evidence-based. So I've been concerned about that for a time. I've been interested in whether tools, so there's a bunch of new tools in public health. I'll talk a little bit about them as we go through the talk, but that have set competencies in public health. So what are the competencies that public health nurses and others in public health ought to practice too? There's been a very good set of competencies that have been developed. So now there's a whole set of national performance standards for public health, so that public health departments are now being accredited, just like hospitals are accredited. There's a whole set of evidence-based guidelines, the community preventative services guidelines that have been created. And the question was whether any of this has had any influence on the programming of health disparities in local communities. And at the end of the day, there is some real questions about how effective a lot of this has been in changing the nature of health equity and disparities at the community level. And an even bigger question is, how is public health nursing contributing evidence to those questions and changes in the populations? And so that has sort of led me to this notion that we are ready for a renaissance. So what does that mean? Well, here's the deal. I ask my colleagues this that are still very much in public health practice, and I say, have we clearly articulated the following questions as public health nurses? So the first one has to do with how do we define our practice? So I know many of you are students in the room, and I don't know if you've had your public health, community health rotation yet. But if I ask you the question about how do you, when you go out in your public health practice experience, how would you define the practice that you're seeing and learning in your educational program? So is it about the health of populations? Is it about diseases that are causing early morbidity and mortality in communities? Is it about health equity, systems, programs, services in a community that assure that the population is treated in an equitable fashion? Is that what our practice is about? That's a question for you all to ponder. I asked my colleagues, what is our agenda as practitioners? So as public health nurses practicing in the environment, what is our agenda? Are we most interested in individuals and families and the health of those cohorts? Do we see our practice as the community? Is it policy? Is that where we think our major interventions ought to be? Is it with systems, the way systems are designed? Is it with society? And apropos to you all, your academic journal that just came out is focused on public health as a global practice agenda. So these are, now I'm not going to answer these questions for you, I'm just going to pose them to you as the things that make me wonder about if we don't have answers to these yet, then the development of these answers could really cause a renaissance in public health nursing. And then the final question is, what is our evidence base? So if I were to ask you, students and all of you, when you provide an intervention to a community, what is the evidence that says that that particular activity works, that gets you the outcome that you're seeking? I'll just diverge for just a minute. The last research I did before I came to New York was asking this very question. We sampled health departments across the United States and asked them about their programming for health disparities. We just asked them to tell us what it was, so that were they working on, you know, obesity programs, cardiovascular programs, diabetes, you know, what were they working on in terms of health disparities. And then we asked them about the evidence that they used to develop those programs. In other words, how did you know, when you developed that program, how did you know it would work? And as many of you know, the evidence is sort of tiered in terms of, you know, the gold standard is that you've done comparative effectiveness or randomized controlled trials, and you're really quite sure that the intervention, whatever it might be, works. Now, you also know that doing randomized controlled trials in communities is generally not particularly the way to go. Communities just don't want to be in one group or the other. So then there's many tiers of evidence, but the question to the health departments was, you know, what kind of evidence are you using? Really, most of them were at, those who had what we would consider some evidence base were really at what we would call kind of promising programs, which means the evidence really wasn't in yet, but it looked like these were promising programs. And I think that that's both optimistic because people were moving sort of up the tier of evidence, but there were many, many, many programs that did not fit into any of those evidence tiers. So do we need a renaissance? I'd say yes. So, but here's the challenge. So, you know, we want to be more evidence-based. We want to be more community and population focused. We want to be more in the business of social equity and health disparities and many, many other things we'll talk about. But here's the big challenge. So preparing future nurses to engage at the practice, the research, the leadership, and policy levels are going to require us to meet many of these challenges. So societal challenges. So we know that a great deal of how healthy we are as individuals comes from our socioeconomic status. So if you are in poverty, and a large percent of our population is, then that is a huge roadblock to get around in terms of trying to work on health disparities and health equity. Individual and community behaviors is a very large determinant of health. So how we choose to live our lives, what we eat, how much we exercise, where we live. You know, where we live matters. Where we live matters. So if you look at health data across the country, from community to community and state to state, the variation is really astonishing. So we all kind of die of the same thing. The top 10, I'll show it to you in a minute, the top 10 are the top 10. But when you get down to community levels, where you live makes a big difference. So we know that individual and community behaviors, lifestyle, big deal, disparities in access treatment, equitable approaches to healthcare and public health. All of these are huge societal challenges that do not respond to a health care intervention. Has nothing to do with whether you visit your provider on a regular basis or not. These are societal challenges. Okay, so we keep this in mind. And then what are some of the other opportunities, if you will? So there's a lot of work in interdisciplinary practice models that I think is very, very exciting. And this is really thinking about getting to the point where we say, okay, we know we can't do it alone, that nursing alone isn't going to solve these challenges alone. We need interprofessional models. It's taken us a long time to think about interprofessional education, even longer to think about interprofessional practice. But I'm very optimistic about bringing the health disciplines together with our colleagues in business and architecture and engineering, where they, you know, these are the people that make all the devices that we use all the time, to really think collaboratively about how we really meet some of these challenges. Leadership, how do we think about our own contribution to leading change in communities? Even if it's not in our job description, how do we take some accountability for that? Policy and advocacy. I used to teach health policy when I was at the University of Washington. It was just my favorite thing to do. But I have to tell you, I'd always start every class, these are graduate students, I'd always start every class with this little, sort of little policy quiz. Basically, it was just basic civics. I won't give you the quiz, but I would predict if I did, many of you would answer the same way my students did, which at the end of the day, it was that we are woefully uninformed about civics in society. Part of it is that we don't read a lot of newspapers anymore as a society, from cover to cover. So, you know, I'm a dinosaur with technology. I love newspapers. I read the New York Times cover to cover. But that's a dying vocation. So we don't so much read the newspapers anymore. We get our news in, I don't know, where do you guys get your news? You've got your, all your laptops are open. You're very savvy with technology. Where do you get your news? All different Facebook and Twitter and stuff like that. Okay, so I get it, but the deal is that we have forgotten how society runs, basic government. So, who's at the top of who really runs government? Who's at the top? We are, right? Citizens, we vote, we are. And just the lack of really attention to civics. So then, if you don't know about that, then it's very hard to be an advocate. Because when it comes to wanting to make change, policy change, it's hard to know exactly how to approach that if we don't know how government works. So that's a big issue. And then big opportunity is the Affordable Care Act. And I'm not going to go into all of that, but there's a huge opportunity within that act for nurses if we choose to take it take it up. So now, I want to now just sort of get a little more focused on this business about aligning the work we do in public health, which is the work about populations, with the work that's been going on around trying to improve the care provided in primary care and doing something about the shortage there of primary care providers, and how that alignment could really make an impact on chronic disease. But first I wanted just to make a bit of a case, and I want to read you something that, now this is all over the literature, so this is not something I just dreamed up. But let me just read you something. So this is sort of to make the case for why we ought to be thinking about aligning these systems and focusing on chronic disease. So by the middle of the 21st century, the US population is projected to increase by 40% to about 400 million people. More than 20% of that population, so this is projecting, more than 20% of that population will be over 65 years of age. 20% will be over 65, an increase from 12.5% in 2005. So in 2005, 12.5% of our population was over 65. So it's projected to increase 20%, to 20%. The white population will be approximately 50% of the population, but the largest increase, so that means 50% of our population will be non-white, and the largest growth in population will be within the Hispanic population and the Asian populations. Because of persisting inequities in health status, these demographic changes will have a dramatic impact on health. Older populations will suffer from more chronic disease, even if age-specific prevalence of conditions remains stable. The projections for prevalent cases of Alzheimer's disease will more than double by 2030. Similar projections have been made for obesity, diabetes, chronic lung disease, and other chronic conditions. In addition, age-adjusted quality of life, as measured by healthy days, will have decreased over time. Now, if that's not enough to motivate us to work in the area of chronic disease, I don't know what is, because I don't like that future projection. I want a different future for our population. So how do we get there? Well, first of all, this is what's causing early mortality and morbidity. And you know this list. This, no matter where you go in the United States, this list is going to be pretty much the same. So these are the major chronic conditions that lead to early mortality. You can read the list. So this is what the data says. So if you read the health status data, this is what you're going to see. But what else is important? What else is important about what's causing early mortality? So actual causes is important. So if you look at this list, the actual causes of this list of diseases are what? Just shout out a few things. Actual causes, root causes. Okay, respiratory fitness, yeah. So physical activity. What else? Nutrition. What is that? Money, right? What else? I guess nobody smokes in Pennsylvania anymore? Yeah. Nobody drinks too much? Yeah, right. What else? Genetics, race and ethnicity, where you, yeah, all that stuff that's the underlying causes. So this list is important. We spend a whole lot of time counting this stuff and trying to figure out how to intervene. But the fact is that under these diseases, there's what we call the actual causes of morbidity and mortality, and they're a very different kind of set of things and a lot tougher to make changes in. What else matters? Well, outcomes matter. So if you were going to make a stab at improving the list we just talked about and the underlying causes, if you were going to make a stab at changing that, what would you do first, second, third? You know, how would you go about that? So let's look at this list. So the Centers for Disease Control has done a lot of work on what they call the winnable battles. Winnable battles. And they've said that when we approach changing the nature of chronic disease in this country, in other words, changing that forecast that I read you, these are some of the things that we ought to keep in mind. First of all is the notion of burden, the concept of burden. So burden isn't necessarily, you know, what's causing the most people one of these conditions, but it's the idea about the burden of the disease on people's lives and living well, quality of life, that kind of thing. The notion of burden, and there's a lot of work in terms of defining that and measuring that. So we need to understand the burden of a disease, and that would put it in a higher priority in terms of outcomes. Disability. So people living with chronic disease for much longer than they used to live longer with disability, and that's an outcome that matters to people. So how well they live with a chronic disease and how well they live with a disability matters for people. The economic impact of a chronic disease matters. You know, you look at the costs of the list. If I showed you the list of what costs us the most money, it would be a little bit different list from the one I showed you before. So economic impact matters. Utilization matters. How much health care one utilizes because of the chronic disease and the disabilities they have matters. And quality of life matters a lot. So the Centers for Disease Control has developed this notion of winnable battles. And they would say that what we ought to be thinking about are, one, the leading causes of illness, injury, disability, and death as one way to focus. Evidence, where we have evidence-based, scalable interventions exist, we ought to start there because we know these things work. Effort does make a difference, so the amount of effort we put into a program matters, and whether we can get results within the first 1 to 4 years of a program matters. Now, those of you in the audience who at least have worked around public health for a long time know that most of our interventions, take many, many years to realize an outcome. So what this would say is we need to make impact in 1 to 4 years. And why is that important? Well, in public health, most of our funding comes from government and policymakers, and they want to see results early on. So what does that say? That means we need interventions that are scalable and that have some kind of impact very early on. So that has to guide us. Now let's look at some strategy. So if we believe this, if we think this makes some sense, let's look at some strategy. So if you believe like I do, if you go back to that slide that said we need to ask ourselves the question is what is our practice? What is our practice agenda? I happen to believe that our agenda is really about populations and communities. And so here's some population and community-based strategies that we know fit the slide that I just showed you. These are outcomes that matter, and they're things that we can do in 1 to 4 years. So one is to focus on this notion of underlying causes. So rather than going after lung cancer, let's go after tobacco use. Because you can look at data around quit rates for tobacco, and you can see some progress in 1 to 4 years. Our impact on lung cancer, much farther down. Doesn't mean we shouldn't be thinking about that, but that's much farther down the line. Lack of physical activity and poor nutrition are things that we can have some move the needle a little bit in 1 to 4 years. Changing environments is important. Now, these are, we could talk a long time about how environments matter, but environments matter a lot. Like we said, where people live matters a lot. So changing the structure of environments takes a while, but things like safe places for people to play and walk, utilitarian walking, so grocery stores in neighborhoods where people can walk to, so they don't have to get in their car and drive. They get utilitarian walking, environments that are safe, sidewalks, all these sort of buildable, environmental actions are things that you can see progress in. And making a difference in inequality within a community, which means that, I don't have to tell you all what that means. It means that you equalize and you assure that all neighborhoods and all people living in a community have access to the same kinds of societal improvements. So you don't just improve one neighborhood, you really work across the population and the whole community. Focusing on primary responsibilities of public health. So if we're focusing on underlying causes, what is our role in public health? First of all, it's really about gathering information and reporting information out so people living in communities know what's going on in their communities. And it's reasonable to assume, and we know this to be true from the work that we did on Turning Point, that people living in communities really do want to know what's going on, and if given the information, are willing to a great extent to act on it. So keeping information inside public health and not sharing it with communities does very little good, but population-based surveillance and health assessments and sharing those with communities, health protection, health promotion, disease prevention programs, and prevention of new chronic diseases is really the focus of public health. So what about this integration? So we know that we are fairly clear about what primary care is doing, although there's all kinds of new models that I'm not going to get into, but all of the new patient-centered health homes and the work on the medical homes and all of these new models for providing primary care in an integrated way and team-based care, nurse-managed health centers, all this really great, exciting new things in primary care. What we need to be thinking about, though, is this idea of integrating what we do in public health, this population-based surveillance, this population-based prevention and health protection and promotion, this prevention orientation, and aligning that in a much better way with what's going on in primary care. So what would this mean for us? It would mean much more interprofessional, interorganizational approaches to primary care. So imagine, if you will, that individuals and families that are members of a patient-centered health home were members of this home where they had integrated care, they had team-based care, they had access to nurse practitioners and specialty when they needed it, were also aligned with very evidence-based prevention programs in the communities within which they lived. So they were not only members of a primary care environment, but they were very much members of a very powerful public health presence where they lived. That kind of integration so that individuals and families felt like they were part of communities and were part of this focus on populations. Now, the current state does not happen that way. Most people living in communities have no idea they're being served by public health. Most people living in communities have no idea why they have where they get their clean water, or the fact that the food that they eat is safe, or the fact that they have access to influenza vaccine as a result of a very powerful public health engine in terms of the development and distribution and provision of vaccines, and on and on and on. Most people aren't quite aware of that. So just imagine if they saw themselves as enrolled or a member of a public health system. And then collaboration around, and to the impact that that could have on chronic disease. Okay, so how about a few models and approaches? Now I'm going to run through this pretty quickly because this is stuff that is all available to you online. It's all available to you online, and I'm just going to point out some of my favorites because this gets at the concern about the lack of utilizing of evidence-based approaches. So there's lots and lots of evidence-based approaches out there to bring public health and primary care in a line and its impact on chronic disease. So this is just a list. I'm gonna go into a few in detail, but there's a national prevention strategy, in part initiated by the health reform movement. CDC has a program called the Power of Prevention where they've put together all the interventions that are population-based, that are evidence-based. There's this new initiative called Multiple Chronic Conditions Strategic Framework. There's a MAPS strategy that brings in media, so it's has social marketing in the strategy, access, support services, a whole range of media-related strategies. There's a couple of fabulous committee reports. These two are just two examples of the Institute of Medicine reports. Future of Nursing, you've all heard about that, right? Yeah, probably more than you wanted to hear about it, but it's really a major roadmap for what we do in nursing, including about how we participate in some of these new strategies for chronic disease. It's become the roadmap for us at Columbia School of Nursing, definitely. And then a new report, soon to be released, called Living Well with Chronic Disease, that has a couple of chapters in there about aligning public health and primary care around improving the quality of life for individuals with chronic disease. So just a few specifics. This is the one on power of prevention. I'm not going to read you all this, but I think just in terms of what works, because we talked about it's within 1 to 4 years, if that's when we want to see some results, we have to go to what works. And these are some programs that clearly work, both for health promotion, for early detection, and for managing care once an individual and a family are involved with a chronic disease. So I'm just going to flash it up there, but this is not so much to tell you, here's a list of things that work, but that there are many things that will work and that we can see changes in that 1 to 4 years. Now for the case for aligning our systems. I just want to take you through this initiative called the Multiple Chronic Conditions Strategic Framework. This is from the Centers for Disease Control as well. This is really based on 4 different strategies that integrate what we do in healthcare and what we do in public health. So it contains, again, this is something that you can go to the web and look for, and then you can see all the things that are in the strategic framework. But there are things in there, evidence-based models that improve care coordination. So we all know that individuals with chronic disease, one of the most powerful interventions to keep people from being readmitted to hospitals with their chronic condition, to allow them to manage their own care, self-management of care, to appropriately use medications in terms of adherence, et cetera, is care coordination. And who are the most powerful providers of care coordination? Nurses. Say it loud. Nurses. Yeah, that's something we know how to do really well. So one of the components of our sort of ideal strategic framework, this notion of aligning people in primary care and in community, is this idea about care coordination. And there's a bunch of evidence-based models for how to do this. Defining healthcare outcomes for multiple chronic diseases, payment reform and incentives. So why is that important? Why should we worry about payment reform and incentives in the payment system? Well, I'll just give you one example. There's a bunch. In many states, nurse practitioners are not paid equitably for the care that they provide. Equitably in terms of parity with other healthcare providers. That's a bit of a disincentive, wouldn't you say? Yeah. So aligning payment incentives and payment reform is really critical to all of this work. Use of information technology, this is a very big deal. Preventing occurrence of new chronic conditions, evaluating models of care, healthcare incentives and interventions, maximizing the use of self-care management. This is really home and community-based services, part of the public health field. Tools for medication management. A lot of this is related to health literacy. A lot of stuff in the literature, a lot of really great research in health literacy. Better tools and information for healthcare, public health, social services workforce. Work on identifying best practices, enhancing professional training. These are all the kinds of things that are in this multiple chronic diseases strategy framework. And then facilitating research. And this, of course, is what we're real interested in terms of certainly universities and faculty researchers, is to look at research to help us understand this business about what interventions and what systems benefit people the most who have chronic disease. And this is both all the different levels of evidence, so from the terms of randomized controlled trials, the use of epidemiology, et cetera. You can see the rest of this. So let's see, let me just do a time check here. Okay, I want to get to discussion. So I'm just going to fly past that one. This is a huge opportunity for us in terms of nursing to make the case for why we ought to be both expanding our scope of practice, not expanding our scope of practice, being able to practice to the top of our scope, leading change in health systems, including in communities, achieving higher levels of education, finding ways to do that, and more effective workforce planning and policy making. And then finally, I want to talk a little bit back to this idea about, just in closing, a little bit more about this idea of a renaissance in nursing and in public health. The public health nursing workforce in many parts of the country, I'm not sure about here in Pennsylvania, but I'm pretty sure it's probably a little bit similar, is shrinking in many parts of the U.S. So the public health nursing workforce in many communities across America is shrinking. And I believe that this has reduced our ability to be highly effective with a prevention agenda throughout the country. I do think that there are some steps that we could take to reinforce the need for public health nurses. One of them is to work on measures that show how we as public health nurses contribute to population health. So it goes back to the first question we ask, which is, what is our practice? What is our agenda? And what is our evidence base? We should be asking those questions, both in academe and in practice. Another one is to define our priorities for practice at the population level. And this again goes back to what is it that we ought to be focusing on. I have a passion around working in the field of chronic disease because I think people are living longer with chronic disease and it's having a huge impact on the quality of people's life, and it's having a huge impact on the amount of money we spend as a society on health care. And a third is to gather data on our public health nursing workforce. I do think that public health nursing should play a major role in the management and prevention of chronic disease, including participation in efforts to develop systems within communities that assist individuals and their families through care transitions. So you've no doubt heard a lot about transitions of care and how important that is for people to transition from inpatient through outpatient, perhaps into long-term care, perhaps home, all of this. I think that's a perfect place for public health nursing to be working. This is, of course, a team effort always with providers in healthcare and public health. But I believe that public health nurses will add considerable value to the prevention of chronic disease at the policy and the system level, including research on effective community level intervention. So I think we're due for a transformation, if you will, for a renaissance. So much of the individual and family services that used to be a major part of practice are now provided within other sectors, or tragically, not at all. This is the safety net that many health departments used to provide. That's really going by the wayside. Sometimes appropriately so, but sometimes there's nobody there to pick it up. We understand that programs toward healthier populations should be the primary purpose of a reformed health system. So I want to say that one more time. We know that progress toward healthier populations should be the primary focus of a reformed health system. The primary focus of most of the reform efforts is around insurance mechanisms, which is absolutely essential. But we need to keep in mind why we care about that. And why we care about that is so we can all be healthier. And this has been, that component, healthier people in healthier communities, has been the expertise of nurses in communities, and we need to renew our focus there. The current approach to health reform is focused on illness. We need to advance the prevention agenda through policy initiatives. Policy is a powerful tool for public health nursing and advocacy at for prevention at the community, the local, state, and national level is important. I also believe strongly that we need to actively engage in practice-based research. There's some wonderful work going on right now throughout the nation, the development of these public health practice-based research networks. These are great opportunities for nurses at the community level to get involved in research at the community level, working on real problems that real people and real communities are dealing with every day, and applying basic research skills to thinking about what works in communities. The research, there's a group called the Association of Community Health Nursing Educators. Some of you may be members of that, and they've been working on a research agenda, and it has many of the same things that we've talked about this evening, focusing on populations, the impacts of public health nursing practice on outcomes, developing our evidence base for interventions, and interventions in particular that eliminate health inequities. So I think this is an important time to focus, refocus on those nurses who work in the community, whether that's in public health, community health, home health. We need to refocus on that part of our practice. I think we need to pay close attention to what's going on as the future of nursing efforts roll out. We need to pay close attention. This is the civics lesson. We need to pay close attention to what's going on with the Affordable Care Act, the health reform legislation, to find out where in there opportunities are for nursing. And they are there. You have to kind of look for them. But they are there. And to articulate about how nurses working in communities could be leading a good deal of the system's work to incorporate prevention into health reform. So with that, I want to turn it over to you for discussion, questions, dialogue, wherever you'd like to take this. I think there's microphones here.
Let's see.
Please.
Okay,
It's on.
Cool. I'm Paula. I'm one of the PhD students here at Villanova. And I feel for all of you students along with me. I guess we're in a 30-day countdown till the end of the semester. So I wish you best of luck with all the papers and exams to follow shortly. My day job is to teach. I'm teaching at a small college of nursing in northern New Jersey. And we're in the process of revamping our curriculum, and I get to be a part of that. And one of the things we're trying to do is change this focus from illness to looking at public health nursing and community nursing being the primary goal that we like our nurses to have. Lots of public speaking is what we like, as well as give them an opportunity to learn how to be a voice for nursing, which I think is a major area we've got to work on. And my question to you is, if I was a novice nurse, how would I get into public health nursing?
Yeah. Well, good question, and it matters where you live. And the reason I say that is because in some parts of the country, if you look at a local health department's workforce, some have a very large public health nursing component. And in some parts of the country in local health departments, there are very few public health nurses left. So here's what I ask people to think about. One is that the skill set that you develop, and probably the kind of curriculum revision you're doing, the skill set you develop as you're seeking a position in a community matters a lot, because when you think about what does it take to look at the health of a population. So if you're the public health nurse and you want to look at the health of a population, sort of like you want to detect what the main challenges are, then you need a toolbox that has epidemiology in it. So I would say to public health nurses, make sure you understand the science of epidemiology so that you can do the community health assessments that every hospital in the country is supposed to be doing. In every community across the U.S., hospitals are supposed to be doing community health assessments. Public health departments do community health assessments. There's all kinds of models for them, so I'd say put in your toolbox surveillance, epidemiology, how to do a community health assessment. I would put in my toolbox a really good understanding of the underlying causes of morbidity and mortality, so really know a lot about the health equity in a community, to really understand a lot about disparities, to have that in your toolbox. Have a lot of tools about prevention interventions that work, so tobacco control, physical activity and exercise. We talked about nutrition, we talked about walkable communities. These are things that are in your toolbox. That toolbox is very different from what it was 20 years ago. So I would say as a new public health nurse, or a new nurse looking for a job in the community, you need to have a whole lot of sets of skills, because if the health department you're applying to doesn't hire public health nurses, you have skills in epidemiology and surveillance and community health assessment, obesity prevention, physical activity, et cetera. So these are things that most universities provide for you all, nurses, students, and it's just thinking about that, that toolbox that you take out into the community and making sure that health departments know you contain those skills. But I would really emphasize the work in terms of epidemiology and surveillance and community health assessment. Yeah.
Now, if I were a nurse and I was just coming out of school, can I actually get a job in public health or community nursing without having to go do hospital work for several years is the practice? Is that
Yeah, that's changed.
specialty changing?
Yeah, that's changed. It used to be that health departments wanted nurses to come with a couple of years of hospital experience. I think most public health departments have realized that that work, while valuable and important, is very, very different from what the role is going to be in a health department. And there's some transferability. Really, it's not that essential anymore. Okay.
Why shouldn't I ask a question?
You should.
Yeah, I should.
And then you're going to answer it.
Sure. But this is a dilemma that I've been thinking about. We have seen, a number of us have seen over the last how many decades, the development of the advanced practice nurse in primary care. Very capable in their skills, their content, and their sense of prevention, patient care, support, and education. But there is a disconnect between this large number of advanced practice nurses and the populations and the government systems that should be supporting these efforts that you're talking about.
Right. And
that's where I see the gap. We have prepared people, but they are dealing primarily on a one-to-one basis or a one-to-family basis, and they're not really connected to a system that's providing for the larger population, even though they have the skills and the knowledge and the preventive orientation to move in that direction.
Yeah. Well, you know, I would agree with you, and I think, I watch our own, so Columbia University has a major focus on advanced practice nurses, and I watch where they go and what kind of practice they're involved in, and many of them end up in highly specialized, working with highly complex patients with chronic disease, which is a good place to have them. But I think in part the development of the doctor of nursing practice for the advanced practice nurse, I think is a result of your question. So how do we bridge the gap between what's going on in the primary care or specialty office, what people are seeing, presenting in their office, and what's going on in the community and in the policy arena? And I do think that the doctor of nursing practice is a way for us to try and span that, I guess, different care environments, if you will. So to be the kind of practitioner who, while they have a practice, is very cognizant of the impact of policy, community on what they're seeing in the office, and then engage in the policy dialogue, the lead change, serve on boards, community boards, et cetera. I think that's one of our opportunities. The development of that new degree. I think it will help us. Please.
My name is Sean Pettit, I'm an assistant here, and I have a question concerning social media
when
it comes to public health nursing.
Yeah.
Obviously with things like Facebook and Twitter, access to health information, health promotion is much wider now, and also with programs like We Go Health, I don't know if you've heard of that or not, makes networking for health promotion for chronic diseases much easier. Do you see an increased role in social networking with public health nursing and the possibility of maybe a social network for public health nurses to discuss policy?
Yeah, I do. I think, personally, I said, I was a dinosaur with this kind of stuff. Our university, our School of Nursing has a Facebook page. I can't even get into it, but I'm working on that. So yes, I do. In fact, there's quite a bit of research that's going on about the use of social media and technology in terms of impacting medication adherence and self-management of different kinds, especially in terms of HIV/AIDS. For example, the taking of the medication regime alone is very complex for people living with chronic disease. AIDS is a chronic disease. And there's been some research in terms of using mobile technology to remind patients when to take their medications or to send other kinds of prevention messages by mobile technology. Yes, I think it's a huge opportunity, and the field of informatics is just exploding. And we have a lot of nurses in informatics, a lot of nurses doing research in informatics. It's a huge new field for nurses. Very, very, very exciting, and looks like there's some real effectiveness around the use of social media for just what you've been talking about. Yeah, it's great.
I just had twofold. One, I just want to comment on that. Presently writing an article for the Journal of Pediatric Nursing, and we're talking about the whole piece of social networking and helping teens quit smoking.
Mm-hmm.
And so they just initiated that piece on who smoke texting that
Right,
just came out.
right,
So,
right.
So I hope if any of you smoke,
Yeah.
use it. An example one is you can text it, crave, and it will give you tools to get right through that craving piece. That's
Yeah, it's really great. Yeah.
I teach community public health nursing at Drexel University, and although I'm an alumni of Villanova, and one of the challenges that I find is that when it comes to critical care and other specialties that are maybe, for lack of a better word, more sexy, students are very excited about that. When we talk about a community and public health nursing, which is really our future,
Yeah.
the excitement is not there. And I want to get them excited about it. And so I thought you had great things to share today, and I'd like to know if there are further things that you can tell me that from a grassroots, the level of this future, the students, how we can get them excited.
Well, I mean, I agree. It's hard to counteract the the media exposure. I mean, a lot of us learn, or we think we learn about healthcare from the media, from television and all of that, and we never see nurses out in communities, working to improve parks and lead campaigns around physical activity, and you never see that. You see all the razzle-dazzle in emergency rooms, and people think that that's the practice of nursing, and that's what we have to counter, is those images of that's what nursing is about. So one, we have kind of an uphill climb around media. The second is that one has to, I guess, be excited by the notion of people solving their own problems to get what public health nursing is about. Public health nursing isn't about solving a community's problems. It's enabling, it's enhancing, it's recognizing, the assets of a community. It's doing the hard work, it's all that, and it moves kind of slow. And so it's not the razzle-dazzle that we want and expect. My most powerful experiences, I think, working as a public health nurse was just, my favorite thing. I felt privileged to be in people's homes. I felt privileged to, be in their communities. I felt, very privileged in working with coalitions of individuals who wanted to solve problems. And if we can find ways of exposing students to those really everyday kinds of things, but where an individual like a public health nurse can really impact somebody's lives, it's finding those experiences. I think, because of the amount of time we have to educate students, we just don't have the time to look for those kinds of experiences. But if we can get our students out into the community, interacting with people on a day-to-day basis, it may not be as exciting as an emergency room, but it's pretty interesting, I think. And especially if you can feel, if you can get to a place where people will feel the injustice. See, I think this is the powerful stuff. The injustice of our society at times for certain segments of the population. that's a feeling that I think is hard to put aside. So if you can take students to places where, and they can see injustice happening, and it's all over the place, you don't have to look very hard, I think that's pretty powerful as well.
Thank you.
You bet. Yes?
Hi, my name is Shane Kennedy. I'm a senior nursing student. Just building off that, what do you think that student nursing organizations can do in terms of public health, whether it be outreach programs that they do, or even legislation through conventions and resolutions and things like that?
Well, I think student advocates are very, very powerful. One is that you haven't yet experienced all the barriers, so you never say, oh, we tried that and it didn't work. Now, someday you'll say, we tried that and it didn't work, but now you don't do that, and you know how wonderful that is? So students are very empowering, and you have, not that you have any time, I know you don't, but you have the energy. You have the energy. And I think, I look at our students at Columbia, and I look at how many of them volunteer in community organizations, in groups. So often they volunteer together, and whether it's nutrition programs or child care centers or long-term care facilities, just volunteering. And then getting politically active. Boy, we could spend a long time on getting politically active. But a group of students, nursing students in particular, who go to the state legislature and meet with legislators around issues of interest to you as students. Let's say it's prevention of chronic disease, or getting people to stop smoking, or whatever you're interested in. To visit with legislators. You don't have to testify before Congress. You just make visits, and you go see them, and you say, I want to talk to you about the power of nursing to change the health of people in my community, and let me give you some examples. You know how powerful that is for policymakers? It really is. It really is. It's not scary. It's really fun. So those are the kinds of things you can do. It's very empowering. All right, well, you've been wonderful. You have a wonderful school here. Thank you very much.